symposium about industrial session, live in a box from Saudi Arabia. Dr. Mohammad Alotaiby, and I don't know, surprises for us? I don't know. وين دكتور محمد؟ موجود ولا؟ دكتور محمد جاهز؟ Live in a box, me and Dr. Musa will be here. أنا ما راح أقعد من الكرسي. تعبت. يلا يا دكتور محمد. We are running late a little bit. شد حيلك.
السلام عليكم.
عليكم السلام ورحمة الله.
So thanks for APUT for this sponsored symposium, and there is no text in this presentation, so I like to show cases. The first case is a 59-year-old gentleman who had PCI to the mid-LAD a few months ago, and he was admitted this time with the hematology for He was admitted with cancer, diagnosed as cancer, and was started on chemotherapy. Okay, while in hospital, he developed acute chest pain with ST elevation, so we were called to triage him. We took him for primary PCI. You see now that the right coronary is normal, and you have seen the occluded, sorry, this is case 2. We have to go back, please.
Yeah, surprised يعني. Okay, go to case 1, please. Case 1.
Can we go to case 1? Can I control this? Okay. Can you please just go on with the presentation, please, slowly, if you can help me in controlling it. So it was occluded stent, and we did balloon angioplasty, okay, and then ST segment resolved, and as part of knowing the reason for that, it's shown here that there is a thrombus, and this was done after balloon dilatation, but there is no malapposition. Stay here, please. So I think 2 points here. The number 1 point is that this is a primary PCI, and the usual pathology is a thrombus, which was proved here. And the second point is why did he develop the instant thrombosis? Could be because malapposition, which was probably rolled out, although we did this pullback after balloon angioplasty, but it turns to be probably his cancer patient, and they have higher incidence of thrombosis. So the OCT sorted out malapposition and tell us about the pathophysiology. Case number 2.
Dr. Mohammed, just...
So you can't stop me at any stage.
Musa Akbar, you saw the case, stent thrombosis. Was it acute or subacute?
This is acute stent thrombosis.
Within 24 hours?
No, the patient had, a few months ago, he had PCI to the mid-LAD.
Okay.
And later on, he was diagnosed as hematological malignancy.
Okay.
He was hospitalized for chemotherapy. And he received the initial course of chemotherapy, and while in hospital, he developed chest pain with ST elevation. So you have to take him for primary PCI, and part of instant thrombosis, it could be due to his hypercoagulable state of malignancy, but could be the initiating factor could be malapposition. So that's why it's important to do imaging, and the imaging could be either imaging.
So this is few months after the stenting happened. So I'm saying,
yes,
as related to the thrombosis of a stent, this is chronic.
So the message here is that
why you call it malapposition? If it's happened, if it's malapposition, it would have happened early. Why happen later on?
We know the malapposition, stent thrombosis can be early, can be acute, subacute, or late. You see, and probably the driving force for that, as early that's acute or subacute, is probably malapposition or non-expansion of the stent.
What was an OCT tell us is malapposition? Can you take us through it?
In this particular case, although you needed to dilate because it's a occluded vessel, then it showed you the pathophysiology, which is thrombus, but it rules out that there is initiating factor could be malapposition. So I think instant thrombosis, by its own merits, is an indication to do imaging. So I think that's an important message. When you have already stent in coronary, and they come with either acute, subacute, or late thrombosis, A class 2A by the guidelines says that you have to do an imaging. And that's why it's relevant here and it's important.
I know it's important, but I'm saying what was on the OCT tells you malapposition. I just wanted to see. I didn't see it. أنا ما عرفت يعني. موسى أكبر, you have a question?
No, as you said, in the stent thrombosis, very important imaging is mandatory to know the exact cause. One reason is malapposition, if you can see it. But the other cause of stent thrombosis is the underexpansion. You can get opposition but not well expanded. And there are cases showing that if you're not expanded very well, sometimes in 85, you should push it higher up to 90, 95 to prevent. So there are cases reported that you will have a good opposition but under expansion, and that will cause as a factor for stent thrombosis.
So this is true. Now, the malapposition, if coupled with under expansion, that's the risk factor for stent thrombosis. And but still, I think malapposition alone, probably there is a conflict in data about the predisposition of for thrombosis. But if you have the combination of two, that's why you need OCT. So the OCT tells you the mechanism that it's thrombus. Second point, it's non-malapposed and expanded stent. So it's true that the combination is important, and probably the determinant is under expansion more than malapposition. But the worst scenario is to have the two together. So that's important message from the first. I think it's important to convey this message that when there is instant thrombosis, whether it's early or late, it's important to consider imaging. And the best probably modality of imaging is to do OCT. Second case, please. I like this discussing case by case. That's probably enrich our knowledge. Now, number two.
وتحملنا شوي ها ترى احنا
لا that's fine.
we're playing the opposite.
No, go ahead. Interrupt me at any stage. That's fine. So this is the second case. Right coronary is normal. Almost. Next, please. So you'll see, bear with me about the repeated loops of angios, just to show you probably that this is proximally is fine. The left system showed a trifurcation left main. Circ is normal. Ramus, some osteal disease. And the LAD, you will appreciate that there are two lesions. One is a proximal, and the second one is mid, which is critical, and preceded by some form of ectasia, another manifestation of coronary artery disease. And the operator decided to do the distal or the mid-LAD lesion. You will see it soon.
It's filling defect.
Yeah, you have two lesions.
Multiple views, trying to figure out where to start. Is the proximal lesion significant? It looks here 70%. And then the distal one, which is in the middle AD, is significant. So probably he will make, soon you will see a wire and doing intervention. If you can help me running it to the point. Let me do it myself
Next, please.
if I
Next.
can.
Yeah.
Okay. So the wire in, he ballooned, and he will soon put stent. So he decided on angiogram to leave the proximal part. He ballooned it, put stent for post-dilated stent. So this is post-dilatation.
This was non-STEMI, doctor?
Sorry?
Was it non-STEMI or?
Yeah, it's non-STEMI. Yeah. And he decided, luckily, to do OCT pullback. Probably his concern was the malapposition, proximal malapposition, because of proximal ectasia. And I think that's a useful information. You will see the pullback distally, and then you will see the stent coming up soon. So distally is, position is nice and expanded. You'll see the percentage of expansion in numbers. You see some calcium. And then as you move to proximal, in spite of post-dilatation, after the branch, you see malapposition. Yeah. You see the proximal malapposition.
Under
It's
expansion
huge.
belt.
And that's why it's useful to do OCT, even if angiographically seems good. And the added value of OCT, in addition to diagnosing malapposition, is to tell you what size of balloon, so you can do your own measurement and do balloon. So after this, he decided to do post-dilatation. The proximal part, I'm sure you have noticed that the proximal lesion, which was for interest, was not having any critical stenosis. So the proximal lesion angiographically was having enough area, and he went back and he corrected the malapposition. Another pullback, you'll see it now. So he confirmed that the proximal lesion he left was having more than 4.5 millimeter squared area, and he perfected the result. So the usefulness of this is that, stop here please, thanks. The usefulness that even if angiographically, if you have any doubt about discrepancy in the distal to the proximal part of the vessel, it's useful to make sure that you are not leaving malapposition proximally.
So you'd have, Dr. Mohammed, you had have used this OCT before and after, because to tell you about how much to expand.
That's the ideal situation.
Yeah.
I pull back these cases from our own library, just some of cases I didn't really know what's going on, but I was trying to read the mind and seeing where the OCT helped in decision making. And that's one of the things, that if there is discrepancy in the area between the distal and the proximal vessel, localized ectasia, and if you do PCI, it might be a good idea to do OCT before, but at least do it after to make perfection of the results. So that's second useful indication of OCT. Third case is a young lady who's 59, no risk factors. She came a few months ago with acute ACS, and she was decided that there is some lesion in the middle AD which was fixed. You see her right coronary now. It's normal, smooth outline, and you see the stent in the middle AD. You'll see it later. So pure, clear right coronary artery, at least luminogram. And you see the left main is fine, the circ, no apparent lesion, and there is a stent which is patent in the middle AD, and there is a tortuosity in the LAD itself. This is very common in ladies, but it might be like suggest that probably the initial pathology was not necessarily atherosclerotic. So the stent is patent. You will see multiple views showing the patent stent. So this means that her presentation now is similar to the previous presentation, and they checked the stent was patent. So they decided to do OCT, make sure that they are not missing anything. Now they decided to pull. When you decided to do OCT, you don't need to use a lot of dye in the angiogram. So make the necessary views and then go to the OCT. But this is sometimes what's happening. You exhaust the angiogram, then you decided to go to the OCT, which is a dye-based investigation. Now this is the pullback of the OCT. You see distally there is no lesion. Nicely you see the external elastic lamina, a normal architecture on OCT. Go on, please. And you will see the healed stent, which was a few months old. Okay. It's already healed. And there is no new atherosclerosis inside the stent. There is no black rupture. No atheroma, no plaque rupture, nothing. Stent is nicely covered. And proximally, again, you see the external elastic lamina, free of disease. So, probably the initial etiology was a scat. So probably if you really do the initial, in the lady, particularly ladies without risk factors, if you start in the initial event with OCT, probably you would save her a stent. So again, this is instant stenosis. You did OCT to make sure that you are not missing anything in the stent. But the message I got from this case is that without risk factor, please try to think of OCT before putting a stent. The next case. This is a Cirque disease with some ectasia, a lot of discrepancy.
Dr. Mohammed, just
Stop here, please.
maybe tell us about the features of SCAD on OCT, and is OCT safe because of the pulsation?
Yeah, it is if you can really make sure that it's a careful wiring with floppy wires, and you go and you test. As long as you think of SCAD, I'm sure this will translate into being careful when you wire, and you make sure with little puffs that you are inside the true lumen. But if you are really concerned, you can do another form of imaging. But in fact, the best to show it is probably OCT, because it shows you the intramural hematoma. The IFOS can be used, but it doesn't really show you and with confidence that this is the underlying diagnosis. So I don't want to transmit this idea that if you think of SCAD, don't use OCT, but be careful, please, that probably you need to be careful with wiring and what type of wires and all this stuff. So I think this is important message to start with the diagnostic, particularly in ladies, particularly with lack of the classical risk factors of coronary artery disease. So this is a third message of usefulness of OCT. The fourth message is this patient who had clear culprit Cirque with a lot of discrepancy and with some lesion with ectasia, the two manifestations of coronary artery disease, positive and negative remodeling. So they decided to do this culprit, wire in, then the butt stent, they will post-dilate. You see this lesion inside the stent, they were not happy, so they decided to go with post-dilatation.
Intramural hematoma beyond the stent.
And after that, they pulled the OCT. And you see, it's difficult sometimes to inject when there is ectasia because of the streaming. But they could see that distal part of the stent is fine. And then there is a gross malposition in the middle of the stent, and the proximal part is fine. So it's the ectasia area which is malopposed. Again, there is no calcium behind, and that's very important when you have ectasia because it tells you what type of balloon. If there is calcium, you might choose to do a non-compliant balloon. But if there is ectasia and no calcium, then it's the time to go for compliant balloon because you want to dilate. And that's what they did. They did post-dilatation with a compliant balloon based on the measurement of OCT. And then they did another pullback, which confirmed that they corrected the mid-stent malposition. You will see it now in the middle of the stent that they corrected that malposition. There is a lot of tissue protrusions, but at the end, you notice that there is no malposition in the middle of the stent. So that's very useful information and reassurance, which is another indication of imaging, particularly OCT. Case number 5. This is a lady who had, long time ago, stent in the RCA. Again, she was lacking the risk factors. She came with in-stent restenosis and extension of the disease proximal. If you are entertaining OCT in particular, you have to predilate well to be able to inject dye and see what's going on. They dilated all this segment. They decided to do more dilatation and to stent the whole proximal part, and then they pulled the OCT. So they did balloon in the distal stent, the distal old stent, and then they stented all this area. And now this is a OCT pullback. You see the distal stent is well healed, but there is, remember, the dilatation balloon started just before the distal part of the stent. And you will see now probably a dissection here which goes into the media, and that's probably related to the balloon. And this is a new stent which is opposed nicely. Then the injection didn't show the proximal part of the stented segment, probably related to the injection, and then they decided to go and do another pullback to confirm that they are not missing anything in this long stented area. So the injection is important. Sometimes you don't have the right injection because of the engagement, because of the dye. So you have to do your best in engaging to be able to clear the blood so that the OCT image will be clear. Now, when you do it for perfection, then you have to remember, you will see it in the next loop, you have to remember the MLD and max for the OCT, and the max stands for perfection after the intervention. And you see it here, distally, good position, well expanded stent, all the way. So that's the MAX. M means there is no medial. Max, I call it DAX. So D, dissection, there is no dissection. A, apposition, and X, expansion. And you see all of these here. There is no dissection distally nor proximally. There is maximum apposition and expansion of the stent. So it reassures you, in a lady who had stent in the past, which is by itself is an indication for OCT, but when you do another stenting, you want to make sure of perfect result, which is shown here. So remember max when you do stenting and OCT. Case number 6. This is a lady who had chest pain, was investigated, right coronary is smooth, there is no lesion. And the left system has some haziness or lesion in the proximal LAD. They are not sure how significant is it. And the lady presented with ACS. So there is a lot of discussion about how perfect is the hemodynamic assessment when there is ACS, even if it is negative. So the operator decided, being a lady, to do OCT. So it's not only perfection of result, it can give you a good idea about the underlying pathology and what to do with the lesions. They did OCT for both, right? This is a branch. This is a branch, side branch. And you see a clear lumen distally, external elastic lamina nicely seen. And as you move forward, you don't see a lesion. But the area of interest somewhere here, you will see it. I will move it faster, just to stop at the area of interest. Here is the area of interest in the proximal LAD, and it shows you lipid-rich atheroma with a thick cap. And the operator decided that this is enough lumen, more than 4.5, and he decided to treat this lady medically. This is probably will have another pullback to show you more. Another pullback to show you the same thing. Clearer pullback, clean wall, well established, the architecture of the artery, normal, till you reach the proximal, which shows you some atheroma with a thick cap and enough lumen. So he decided to stop at this stage.
Here.
That's probably the area here. Somewhere here, thick cap. And I know this is an interesting topic because we don't know what to do exactly with TECFA. But probably if the cap is thick and the lumen is enough, you don't need to do anything apart from medical treatment. So these are 6 cases. I hope I illustrated some of the indication of OCT, and it's open for discussion.
Excellent. Thank you very much. Right, Musa Akbar, the acronym of MLD Max, pre-PCI OCT, you prepare your lesion by knowing the morphology, length, the meter. Then post-OCT, look at the max, which is medial dissection and expansion and apposition.
Yeah.
Your comment.
I want to ask you for the last case. Perhaps in the RCA at the beginning, there was a burden of the, there is a black burden with a thin cap. And what you will do, especially if you put FFR or RFR becomes negative and you have vulnerable plaque, and vulnerable plaque means thin cap. So, and that may explain, so would you do something or just leave it because FFR is negative?
Yeah, this is an interesting issue because FFR could be false negative when they have acute presentation. And then when it comes to the imaging, there are data from ultrasound which talks about the black percentage plus how thick is the cap or how thin is the cap, 60 micrometer. And we have the same data when it comes to OCT, and that's from the insider of lumen 4, that if there is probably the cap is more than 75 micrometer, probably you would achieve good results with medical treatment. That's intensification of anti-lipids and antiplatelet, and they do fine with medical treatment. So that's a hot area. We don't know exactly what to do, but we have clear criteria of how to manage them medically. If you did OCT, there is no black rupture, there is no thrombus covering and presumed black erosion, then I think on enough lumen, I think these 3 criteria tells you that it's safe to do medical treatment.
Yeah.
Excellent. So I think thank you very much, Dr. Mohammad, Dr. Musa. We need to move to the next session, and Dr. Waqar, please, you lead the session.
Thank you.